medicine professorial grand rounds. So I really hope everyone can join on person or online to support JEPSA. As you know, he's a internationally recognized investigator and cardiologist who's really had an impact and continues to do so, in interventional cardiology. And so we're looking forward to celebrating his achievements and for him to teach us this coming Thursday a.m. So please do your best to join and support JEPSA. Next week at this time, we will be having a faculty meeting. This is a little off cycle because we have the Calabrese lectureship next week, which I'll speak to in a moment. I will send out a reminder at the early part of next week with a very brief agenda, but I wanted to highlight for the faculty who are listening that we will spend the time with a very brief high-level overview of cardiovascular medicine in our department's response to the funds flow era and how, and just to have a discussion around that in advance of small group meetings that are already being scheduled with core groups of faculty, just to answer further questions. I think suffice to say that I believe we are going to do well. We're not going to be obviously changing anything about who we are and how we do things, other than to be more cautious in this new era of funds flow and how we ensure that we work smarter to take care of our patients and ensure that our finances are sustainable into the long term. So all good news in general. Tough times and everything that's a change always makes people anxious, but I want to ensure that you all do your best to join us in person if at all possible, or by Zoom next Tuesday for that general introduction to funds flow that I'll lead. Later next week on Thursday in the morning, we will have really a phenomenal guest joining our section to give the annual Calabrese lectureship, which is one of our honorary lectures hosted by the section in the department. It'll be at 8:30 a.m. next Thursday here in Fitkin. Noel Bailey Mertz is a world-class colleague who has done so much to advance our understanding of how to manage ischemic heart disease in women. And she'll be focusing on that theme throughout her visit with us. We are scheduling a series of small group meetings, and with Jeff and Dana's help, we're finalizing the schedule, which we'll finish later on today after this afternoon. And so please be aware of that Thursday where we'll have her give a grand rounds to the entire community at 8:30, and then she'll have a fellows meeting and perhaps another town hall or seminar at 12 and 2 o'clock, I think it is. But we'll send that out around later. So with that, Rohan, please take it away, and you can advance the slides here.
Thanks, Eric. So with that, I think, Eric already prefaced that this is already one of the, highlights of our Grand Round series to have our fellows, especially those in the final year of their training, presenting on their science and the work they've done, or an important clinical domain or research domain that they find interesting. Today we have 2 star fellows with us, and I'm going to sort of introduce the first one and then go to the next one. Both of them have done amazing work in their domains, and the first speaker we have today is Dr. Inga Melvinsdottir, who is a 3rd-year fellow. She did her medical school training at the University of Iceland. But after that, she did an internal medicine residency at the University of Wisconsin-Madison, after which she moved to Whiterick to do a research fellowship in multimodality imaging research training under Dr. Al Sanusis. And then Al couldn't be here today for some personal reasons, and so I get the honor of introducing Inga. And then she did a clinical cardiology fellowship, which she graduates from this summer in the next month. And after that, unfortunately, we lose her to Georgetown, where she goes to DC for a year of doing structural echo fellowship. So with that, I'm going to actually, I thought I should have gone through this. This is she's going to talk about multimodality imaging guided intramyocardial delivery of imageable hydrogel post-MI, which improves strain associated with integrin activation. It's a mouthful, but it prevents you from saying it. Thank you.
Thank you so much. So hopefully after this presentation, I hope to convince you that intramyocardial hydrogel injection 5 days post-myocardial infarction may result in reduction in post-myocardial left ventricular remodeling and increase angiogenesis. So this is the overview of my talk. I'm going to talk a little bit about the background and study objectives and designs, and then going over the result to some of the conclusions that we can draw from all this, and then some acknowledgements at the end. So as I'm sure you all know, the most common cause of heart failure is coronary disease, and particularly in systolic heart failure, where it accounts for almost 2/3 of the cause. So these maladaptive changes that occur in the surviving cardiomyocytes in the extracellular matrix after myocardial injury lead to this pathologic remodeling of the left ventricle with dilatation and impaired contractility. So here on the bottom, you can see a schematic representation of the cardiac cycle in ischemic myocardium of the left ventricle. When the isovolumetric contraction starts at an early systole, when the ventricle contracts with no corresponding volume change because of the closed valves, this builds basically up the pressure to overcome the pressure inside the aorta, which then opens up the aortic valve, and then the cardiac cycles continues. So you can really appreciate that the infarct here the infarct here is floppy and it's thinned out, which is not really helping with the cardiac cycle. So in its simplest form, given by Laplace's law, a left ventricular wall stress is directly proportional to the diameter of the left ventricle and the ventricular pressure, and then is inversely proportional to the wall thickness of the left ventricle. Excuse me. So therefore, when comparing two hearts, one heart with normal dimension and another with dilated left ventricle, the aortic pressure, and assuming that the aortic pressure is the same in both hearts, the dilated heart must create a larger tension to overcome the same aortic pressure to eject blood because it has a larger internal radius and wall thin. So thus the dilated heart has to create a greater load or tension on these healthy cardiomyocytes. So this is where hydrogel treatment comes in. So over the past years, both time and resources has been invested into the evaluation of biomaterials and particularly injectable hydrogels as a treatment to modulate this dynamic left ventricular remodeling process. And primarily through two ways, with mechanical bulking. So injecting this bulky material into this thin, floppy myocardium to stiffen up and thicken the wall, basically to relieve the tension on the surviving or the normal myocardium. And then with second, to use this as a delivery vessel, basically to deliver local therapeutics, for example, to stimulate angiogenesis or deliver stem cells and so on. So in clinical trials, both open thoracotomies and minimally invasive catheter approaches have been used as the delivery methods of the hydrogel. So this is one example of an intramyocardial hydrogel used from alginate that made it into human trials. We see the preclinical studies, a canine study here to the left, showing decreased left ventricular remodeling, evident from decrease in left end diastolic wall motion, and diastolic volume, and systolic volume as well, and then increase in the left ventricular ejection fraction and stroke volume. So then on top here, you see a schematic representation of the delivery method of how it was delivered in humans. So they used a kind of this anterior limited thoracotomy to deliver it mid-ventricle and mid-myocardium, and randomized to either just standard medical therapy versus the intramyocardial hydrogel injection. And then you can see on the bottom graph, this is a 6-minute walking test distance. You can see that that is increased in the treatment group compared to the control group at 6 months, and then again at 12 months. And then turning our attention to hyaluronic acid-based hydrogel. So in this study, using a rat model, injectable acellular hyaluronic acid-based hydrogel was injected about 2 weeks after myocardial infarction, after permanent ligation of the left circumflex. Then the animals were euthanized about 4 weeks after MI, or about 2 weeks after the delivery. So as you can see here on the bottom, there was significant increase in the wall thickness of the animals that received the hydrogel, and actually also a decrease in the infart size as well. And one of the theories that the authors had is behind the reason why this was observed was increased angiogenesis. And they were able to show that with increased arterial count and capillary index in the hydrogel group compared to the control group. So angiogenesis represents the formation of new capillaries by cellular outgrowth from existing microvessels, and this occurs as part of a natural healing process after an ischemic injury. So during angiogenesis, endothelial cells must adhere to one another and to the extracellular matrix in order to construct and extend new microvessels. So the specific alpha V beta 3 integrin has been identified as a critical modulator of this process. However, it has been also detected in osteoclasts and inflammatory cells as well. And then using mariciclotide, which is a compound that directly binds to the activated form of the alpha V beta 3 integrin, provides us with an opportunity to image this molecular process non-invasively. So this has been used in humans, primarily in research setting only, and a recent phase 1 study showed a favorable safety profile. And here to the left here, you can see an obvious myocardial perfusion defect here in the anterior wall about 3 weeks after an MI and stent. And you can see a corresponding increase in the alpha V beta 3 targeted imaging agent, or the mariciclotide, in the anterior wall, both on the short axis and in the long axis images. So hyaluronic acid, this is a common component of hydrogels that is used for intramyocardial therapy. It is a polysaccharide commonly found in the body. This particular hydrogel that we are using has a shear thinning and self-healing properties. This was designed by a group at University of Pennsylvania. And the characteristic of the self-healing and shear thinning properties allows us to inject the hydrogel through that small syringe, through the tiny needle, and right directly into the myocardium, and still remain as a one cohesive piece. So this gives us the desired effect of bulking this ischemic floppy myocardium that we're wanting to do. And in addition, what is unique about this gel as well is that it is encapsulated with iohexol. So this allows us to image the gel under X-ray, as you can see here on the fluoro images here, shortly after it was delivered into the myocardium. So this basically allows us to directly track where the hydrogel is located within the myocardium and confirm the placement within the infart. And you can clearly see here that it is clearly within the perfusion defect, evident by this kind of green discolorization within the infart after a permanent occlusion. So one of my co-fellows, Ricardo, published this last year from acute infart porcine model. And here the the hydrogel was delivered within the infart zone about 1 hour after creation of infart with permanent ligation of one of the coronary arteries. This basically showed increased strain within the hydrogel region compared to decreased strain within the myocardial infarct-only group, and decreased compensatory strain in the remote segments compared to increased in the hydrogel or in the control group. So thus, we wanted to take it one step further and perform a study to see the effects of the hydrogel that was delivered a few days after a myocardial infarct, and study the effects on the left ventricular remodeling 1 week after hydrogel delivery. So our hypothesis is that intramyocardial injection of this novel imageable hydrogel will result in deacceleration of the left ventricular remodeling and then increased angiogenesis. And also hypothesize that our multimodality imaging approach to the hydrogel delivery will provide us with a desired location, and in addition to allow us to track the regional anatomical, physiological, and molecular events following the injection. So we had 3 aims to utilize this high resolution CT imaging and a novel 3D strain analysis method developed by one of our group members or team members to evaluate the effects of the hydrogel, particularly focus on post left ventricular remodeling, and then using the hybrid spec CT molecular nuclear molecular imaging to evaluate the angiogenesis and response and perfusion following the direct intramyocardial hydrogel delivery. And then finally, use the nuclear images also to guide the delivery into the desired location within the mid-infarcts. So we had a total of 14 Yorkshire pigs, about 8 in the treatment group and 6 in the control group. On the first day, the animals were subjected to 90-minute balloon occlusion and reperfusion injury prior to some baseline imaging and post-MI area at risk assessment. And then on day 5, the animals were evaluated with thallium images to detect the perfusion defect size and location. That's to guide us how and when or where to deliver the myocardial, then the hydrogel, excuse me. And then the animals were randomized either to intramyocardial hydrogel delivery versus saline with similar concentration of the iohexol compared to the hydrogel. Then the animals were then brought in about 7 days later or on day 12. And then we again evaluated the perfusion defect with thallium imaging and CTA. And then shortly after the euthanasia, we sent the left ventricle for histological analysis and then for gamma wall counting. So this is one example of the delivery of the hydrogel to an animal that had a diagonal 1 occlusion and reperfusion injury. So after confirming the location and size of the infarct with thallium images, the hydrogel was delivered via this 3x3 grid that you see this here on this video right here. Basically, this is to ensure equal distribution of the hydrogel, and then it was indeed mid-myocardially delivered as well. And then once the chest was closed, a coronary CT or a CT angiography was acquired to confirm the location of the hydrogel, and then superimposing that to the thallium images that we got prior to the hydrogel delivery, we confirmed that indeed this hydrogel was within the infarct location. So then jumping over to the results, as you can see really on these images, the hydrogel is clearly visible within the myocardium on coronary or CTA imaging acquired roughly about 2 hours after the delivery. However, bringing the animal back in at day 12, the hydrogel was no longer visible, indicating that the iohexol diffuses out from the hydrogel within that time period. Just looking at the Hounsfield units of the segments that had hydrogel in them, clearly it has significantly increased Hounsfield units compared to the remote segments, and comparing those exact same segments again about a week later, there is no difference in the Hounsfield units. So clearly not visible. So here we see the left ventricular volume and ejection fraction changes. To the left, we see a change in end diastolic volume comparing day 1 to day 5, day 1 at baseline and day 5 prior to hydrogel delivery. And as one would expect, after a myocardial injury, the end diastolic volume goes up in both groups. However, comparing day 5 to day 12, in the treatment group, it goes down. So it goes back to its baseline. However, in the control group, it continues to increase. And then looking at the change in left ventricular ejection fraction, again, as one would expect, the change from day 1 to day 5, the ejection fraction drops. However, it increases in the treatment group, but continues to decrease in the control group. Then we looked at the wall thickness at 5 different time points throughout the study. And by estimating on the thallium images, we're able to identify the infarct segments, the border segments, and the remote segments. And just primarily looking at the infarct segments, we can see that just on day 1, from baseline to shortly after the initial myocardial infarction, the wall thickness increases in both groups, probably because of some swelling and edema immediately after the myocardial infarction. Then it kind of goes back to baseline at day 5 prior to hydrogel delivery. And then immediately post, or roughly about 2 hours post hydrogel injection, as one would expect, there is increased wall thickness in the treatment group compared to the control group. However, this is no longer significant about a week later. If you look at the end systolic wall thickness, again, similar pattern, increases shortly after MI, goes back to baseline about day 5 prior to hydrogel delivery, then kind of trends to be increased about shortly after the hydrogel delivery, however, significantly increased about a week later. So the reason behind this observation about this dynamic wall thickening is probably due to the shear thinning and self-healing properties of the gel, and probably needs some time to settle in its final form. The wall thickening, defined as end systolic wall thickness subtracted by the end diastolic wall thickness, we can see it drop significantly shortly after the myocardial infarction, kind of remains stable on day 5 pre and post hydrogel delivery, but starts to go up significantly in the treatment group compared to the control group about a week after hydrogel delivery. So this is a busy slide, I know, but this represents kind of the whole results from the nuclear data set. So this is both thallium and technetium labeled miracyclotide in vivo and ex vivo nuclear images and the well counting results. In the middle here, we see the in vivo at day 12. Again, that's 12 days after hydrogel delivery. Clearly see where the perfusion defect appears to be and increased miracyclotide signal within where the infart is, which is also seen in the 17 segment model bullseye here. And then it's even more clear when imaging the ex vivo or excised hearts shortly after euthanasia. We can see that this is a mid-LAD occlusion or reperfusion injury and see a clearly increased alpha V beta 3 activity within the infart zone. Then the top left shows the average thallium uptake after dividing the segments into 3 groups. We defined normal perfusion as all segments within each animal in the 90th percentile. So according to that, categorize them as remote segments, anything above 80% of that defined normal, and then border segments, anything between 60 and 80% of that defined normal, and then infart segments, anything below 60% of normal perfusion. So, and then looking at the technetium labeled miracyclotide count, indeed, there is no difference in the remote and border segments, however, increased in the infrared segments in the treatment group, but not so in the, it was more so, excuse me, in the control group. So then there was significant variability within the groups of animals. So we report the change in radial strain. So here we see the change in radial strain from 1, again, at baseline prior to any kind of therapy, and day 5 prior to hydrogel treatment or hydrogel delivery, about 4 days after myocardial infarction. So according to the thallium perfusion and the Hounsfield Venus, we were able to divide the segments into infart segments, hydrogel segments, border segments, and remote segments. So we can see that there's a drop in radial strain in almost all segments, but there's a larger drop in the radial strain within the segment that ended up being injected with hydrogel. So they had a significant drop in function. Then again, comparing day 5 to day 12, day 5 prior to hydrogel delivery compared to a week after hydrogel delivery. Again, we see a drop in almost all segments in the radial strain, indicating lower function. However, there appears to be a lesser decrease in radial strain within the border segments in the treatment group compared to the control group. And then finally comparing baseline on day 1 to day 12 or 1 week after hydrogel delivery, no significant drop in the radial strain in the remote segments here in the treatment group. However, significant drop here in the control group. And then, as I alluded to further, there was a significant drop in the segments that ended up being injected with hydrogel. And indeed, the function really dropped even further within the segments that received hydrogel, and significantly more so than the infart segments in the control animals. So this is a nice visual representation of the ex vivo well counting data and the in vivo CT strain data on day 12 on one animal that had a first diagonal occlusion and reperfusion injury. To the left, we see a fused photograph of the mid-ventricular short axis slice with a superimposed thallium perfusion. So we can clearly see here is the infart segment and here is a border segment. Similar, same slice, just superimposed with the technetium labeled miracyclotide data, increased miracyclotide within the infart and border zone. And again, significant drop here in the radial strain on those corresponding in vivo short axis slice, both in radial strain and circumferential strain. So we were able to correlate the myocardial strain to the gamma well counting data. And when correlating the radial strain from border and infart segments to the technetium labeled miracyclotide, there was indeed a negative correlation in both groups, indicating reduced radial strain where there is higher miracyclotide signal, again, in both groups. And then a similar calculation for the circumferential strain, but however, only statistically significant in the treatment group, indicating, again, decreased circumferential strain correlating with higher miracyclotide activity. This relationship was not really significant in between thallium and radial strain. However, in the control group, there was a negative correlation between thallium and circumferential strain, indicating more negative or more normal circumferential strain in the segment with higher thallium activity or normal perfusion. However, again, this relationship is not present within the treatment group. So finally, we were able to do some limited histology on the myocardial segments. But again, please note that most of the left ventricle or tissue pieces we sent for gamma ball counting. So we were only able to do one short axis slice per animal. So we chose a mid-infarct slice that usually had myocardium. Hydrogel in the myocardium. And here we can see a treatment animal, and here's a controlled animal. We can indeed see that the hydrogel is mid-myocardially located. And you just have to believe me that there is a beginning of another blob right here. And you can see that the infarct is located quite in the vicinity of the hydrogel. Then magnifying and looking particularly at the alpha V beta 3 integrin activation, we can kind of visually see that it appears to be a little bit more intense within the treatment group compared to the control group. Not maybe less obviously so of the factor VIII expression as well, which is a well-established angiogenesis marker. And then because I mentioned that alpha V beta 3 integrin is also involved with inflammation, and one expects inflammation in myocardial infarct as well, we can see increased PCNA and IBA1, which are markers for inflammation and necrosis. When doing direct quantification of the immunohistochemistry, there is increased signal of alpha V beta 3 integrin and factor VIII, again, established marker for angiogenesis, and also appears to be not a significant difference in the amount of viable myocardial tissue evaluated by Mason's trichrome stain that we did earlier. And there was no significant difference in the IBA1 expression either. Now, this is one of the final slides, but because we had this 3x3 grid, there inevitably in one and a few of the animals, there were some delivery into the border zones of the hydrogel. So you can see the infarct right here, and these are the hydrogel blobs right here. So if we look closer, we don't see any significant inflammatory response evident by PCNA, MMP9, or IBA1. There's this halo of fibrosis immediately surrounding the hydrogel, but the structure and architecture of the tissue appears to be pretty intact. So the conclusions, the delivery of iodine encapsulated theranostic hydrogel to the infarct region with multimodality imaging appeared to be successful. There was decrease in left ventricular remodeling evident by increased wall thickness, decrease in diastolic volume, and increase in left ventricular ejection fraction, and favorable regional strain. And then the radiotracer-based imaging appears to provide this novel non-invasive approach to evaluate treatment response following angiogenesis-targeted treatments, for example, the hydrogels. And then increased alpha V beta 3 integrin in the infarct region post-hydrogel delivery suggests the potential stimulation of angiogenesis, considering the absence of obvious inflammatory markers. But however, we need obviously further research to really establish and elucidate the role of the alpha V beta 3 integrin activation in the setting of hydrogel delivery. Finally, I want to thank obviously my family for their never-ending support, my children, Gunnar and Gida, my pride and joy, and my husband, my rock. Of course, my mentor, Alcinusas, unfortunately cannot be here today, but he has provided me such incredible teaching and incredible opportunities. So I want to obviously thank him from my bottom of my heart. Ed Miller for believing me in the first place. Thank you so much. And of course, my T32 fellows and White staff that taught me so much. And I owe them everything. And then of course, my clinical cardiology fellows that keep inspiring me to be a better cardiologist. Thank you.
That was excellent. We might keep the questions to the end so that we can keep going, and then we'll have all the questions together. Next up, I have the honor of introducing Evangelos Economou, who I've known for the last 4 years, and time has flown by. So I met Evan when he was a second-year internal medicine resident, and I was a 4-month faculty at Yale. And it's been a fun journey working with him over the last 4 years, and then getting to work with see him develop as a scientist. But even before I say that, Evan graduated from the University of Athens as a valedictorian. Then he went to University of Oxford, got his DPhil there, where he was successful and did amazing science, which I won't get into so that he can tell about his science. But I would want to say things that he won't say himself. I would say that he's a established clinician investigator masquerading as a fellow, which I think, and I'm glad it's the last year of that sort of, yeah, second to last year, but like soon to be last year. And I think, he's won numerous awards over this time. He's won the ES Young Investigator Award twice before he came to Yale. And since he's been here, he's won the Elizabeth Barrett Connor Award at AHA, which is a very prestigious award, the Robert Levi Award for Epi and Lifestyle Young Investigator Award, the Northwestern Cardiovascular Young Investigator Fellow Award, as well as most recently the Heart Tank Winner Award at the ACC. And these are every single award he's participated in, by the way. So there is none that he hasn't won. With that, I'm going to just pass it on to him. He is From Pixels to Prognosis, a journey into AI-driven cardiovascular biomarkers.
Well, thank you, Rohan, for the kind introduction. Thank you, everyone, for being here today. I hope that over the next 25 minutes, I will manage to share some of the enthusiasm that I have about developing digital biomarkers and using artificial intelligence in a way that is informed by what we know from our clinical knowledge and from biology to define better biomarkers to better diagnose and prognosticate cardiovascular disease. Now, as we normally do, I'll start with the case. And this is a hypothetical case of a woman in her 60s who presents to her primary care provider, maybe with some atypical symptoms, some atypical chest pain, gets referred for further testing that includes maybe an ultrasound, maybe an ECG. They're all normal at the time. The patient is reassured. Then many years go by, and at some point, the patient comes to the emergency room with some shortness of breath and dyspnea on moderate levels of exertion. By the time she gets to the ED, her symptoms are better, but she does get a point of care ultrasound while she's there. She gets an EKG. She gets a CT scan. Mostly everything is reassuring. Gets referred home and her primary care provider for further follow-up. But her symptoms do persist. And at some point, she comes back and she has 2 recurrent hospitalizations for heart failure, at which point she gets extensive testing, including more echocardiograms and more EKGs and more testing. And at some point, someone asks the question, oh, could we be missing something all along? Why does this keep happening? Could it be a condition that we haven't thought about? Could it be cardiac amyloid? And she gets sent for confirmatory testing. And then the treatment that is now available is started, but unfortunately with some delay. The thing I would like to focus on, though, is that throughout this time, this patient's digital footprint has been increasing at an exponential rate. So she's been getting testing throughout this time. And therefore, there's more echocardiograms and more ECGs that we've been accumulating over many, many years. But the diagnosis is not established until the very late stages. And therefore, one question for us as cardiologists, as cardiovascular imagers, as data scientists, is can we use clinically informed, biologically informed artificial intelligence to move the needle and hopefully diagnose that condition sooner, or at least identify the patient's trajectory so that we can refer for more timely treatment and intervention. Now, I know what many of you are thinking, which is probably that's not always feasible. For example, searching for a condition like that very early might be like looking for a needle in a haystack, or maybe the phenotype is not there, the condition has not fully evolved. But the contrarian might say that there are things that we could be probably doing better. For example, maybe some patterns were there, but they just happened to be invisible to the naked human eye. Or maybe patterns were there, but they were invisible to the eye of a non-expert. Or maybe just the way we've been measuring things and we've been reporting things is not precise enough. And therefore, trends that are there across time are lost and are not, we don't see them. For example, maybe diastolic function or left ventricular hypertrophy were reported in different ways. And maybe we could not see the trend that was there all along. So why do we need digital biomarkers? And these are the thoughts that I first started having as a medical student back in Greece. And we would spend a lot of time, as we still do, memorizing all sorts of scores and algorithms that are there to prognosticate and diagnose cardiovascular disease. These are just my legible notes, learning about CHA2DS2-VASc in 2012, 2013. I'm not really sure. It was a new thing then, or learning about who needs like lipid-lowering therapy based on pool cohort equations. But around the time, there was already evidence showing that those scores, they do a good job, but they don't do a perfect job. In fact, the statistic for diagnosis or prognosis is often less than 0.75 or around 0.7. So we don't really pick up all the patients that are going to have the event, which is probably good, but we also want to do a better job than that. And I think one of the reasons why that happens is because if we take, for example, CHA2DS2-VASc, and we focus on example on the H, which stands for hypertension. So we will assign a binary class of 0 to 1. Assuming we have a patient in clinic who has a blood pressure of 150 or a 70, like, are we going to give them a 0 or a 1? How much do we need to see to assign the diagnosis of hypertension, give them that that score of 1? And there are more questions than that. For example, what does their echocardiogram look like? Are there signs of end organ damage? Do they have left ventricular hypertrophy? What does their LV function look like? What does their left atrium look like? What does their EKG look like? Is there evidence of long-standing hypertension contributing to electromechanical remodeling? What does their fundoscopy look like that we never look at? And obviously, every patient may fall on different ends of that spectrum. And therefore, there are infinite different possibilities of phenotypes that we just cannot capture if we simply rely on a binary 0 or 1. In fact, biomedical data are very complex. So if we take the average transthoracic echocardiogram that was done in this hospital system in the last year, the average size of information, of images, of videos that we acquire over 40 minutes, 45 minutes, is approximately 400 megabytes of data over like 90, 100 clips. Now, just to put things into perspective, this might not sound like a lot. It is, though, a significant amount of data. If we compare it byte to byte, it's almost 900 times the size of Homer's work, 100 times the size of A Song of Ice and Fire, and somehow just 5 times the size of a modern-day music album. When we're in the echo lab and we're reading an echocardiographic report, we actually narrow things down to less than 100 words, right? That's 0.2 kilobytes of data. And this is because we try to distill all that information into something that is clinically useful to whoever's going to read the report. Somehow, though, in that process, we narrowed down the size of the data by a factor of almost 2 million. And obviously that makes sense, because if we look at for example, at those 400 megabytes of data, most of it is, for example, noise, artifacts, random variation, information that has no diagnostic or prognostic value. And what we do report is the visible labels that have diagnostic and prognostic value that we can see and we can put into those 100 words. But what we're interested in is the layer on top of that, which is what we call hidden labels. Labels that have diagnostic and prognostic value that the human eye may not necessarily be able to see. And therefore, we want to develop AI biomarkers that do not just do what humans can do, like automating or accelerating what humans do, but ideally augmenting what we can do. So providing that extra layer on top so that we can better diagnose and prognosticate cardiovascular disease. Which brings me to the 3 layers where I think digital biomarkers can really be helpful. The first one is in discovery. So I think they can provide new knowledge where no one else is looking. The second item is standardization. So we can maybe do a better job of reporting our measurements and providing more precise phenotyping. And the third one is they can provide assistance where assistance is needed. And that is valid both across higher resource and lower resource settings, where, for example, there might be like a lack of expert readers or operators. We don't always get Dr. McNamara reading our echo. So, or there might be time constraints. And I'm going to give you today examples for all 3 of those items and how we've implemented that in our work to sort of demonstrate the value of digital biomarkers. But first, a bit of autobiography. How did I get interested into this? Most of you know me, but for those of you who don't know me, as you can guess, well, I guess from the introduction, the name and the accent, I was born in Athens in Greece. The only child in a family of 2 pharmacists, who really inspired me to pursue sciences and really taught me how to work hard. 2019, I was 17 years old. In Europe, we have to decide what we want to do with the rest of our life when we're like 17. Somehow I decided to go into medicine. I've never regretted it since then, mostly because that's where I met my wife. In 2015, I started having, as I was ready to graduate from med school, I started having those thoughts about, digital biomarkers, and like, is there maybe something that I could contribute in that domain and improve like how things are diagnosed and predicted. And I got the amazing opportunity to move to the United Kingdom, the University of Oxford, for 4 years, where I spent there 4 years doing a PhD under the supervision of my first mentor, Dr. Antoniadis, who at the time and still is leading this amazing cohort called the Oxford Heart Vessels and Fat Cohort. So these are patients who are referred for CABG or for valve surgery. And before their surgery, they undergo this extensive preoperative phenotyping that includes pre and postoperative echocardiography and coronary CT imaging. But then intraoperatively, there's extensive biobanking that is taking place. So we take samples from their epicardial adipose tissue, their pericardial adipose tissue, subcutaneous adipose tissue, as well as myocardial samples, vascular samples. And that truly creates like a huge biobank that we can use for further ex vivo studies and further profiling. And the focus of the lab at that point, and still, is to better explore the interplay between the adipose tissue and the cardiovascular system, both in terms of the endocrine and the paracrine interplay. Which brings me to the first layer that I alluded to earlier, which is where I think we can use AI and where I've seen AI being used to derive new knowledge where no one else is looking. So the key observation at the time was that vascular inflammation, that we know is a causal component of atherogenesis, in the presence of vascular inflammation, the release of inflammatory mediators from the infiltrating inflammatory cells in the vascular wall into the adjacent perivascular fat induces phenotypic changes and biological changes in the perivascular fat. So the fat can actually sense that something is happening. It's probably a minimal version of what we see when we have acute cholecystitis and there's perivascular fat stranding. Think about it that way. But it's obviously like much less pronounced in the coronaries. And we wanted to measure that as a surrogate marker of coronary disease, cardiovascular risk, and vascular inflammation. We turned to coronary CTA that was picking up in popularity at the time, and obviously provided great ways to look at the vessels, the myocardium, the cardiac chambers, and the cardiac structure. But there was no way to look at the perivascular region at that time. But obviously, this is not information that we segment out. When we get a coronary CTA, it's not like we say, don't look at the perivascular fat, just throw it away. It's there, except we're not looking at it. So what we spent 4 years on is defining a way and standardizing a way to look at the perivascular fat and determine whether specific radiomic phenotypes captured cardiovascular risk that we could not capture using standard approaches. But what I really loved about the work is we always wanted to know exactly what we're measuring. So we have in vivo imaging in those patients, but we can also get ex vivo imaging. We can get the adipose tissue explants and scan them across different scanners and correlate what we see under the scanner with what we're measuring in the lab. For example, when we look at the gene expression profile of adipose tissue inflammation, adipose tissue fibrosis, and the extensive remodeling that happens in the adipose tissue in response to coronary inflammation. So we automated over a couple of years a method that allows us to, on any coronary CTA, extract the perivascular fat and automatically compute different radiomic features from that. And we narrowed it down to a couple of biomarkers that we then extensively validated across more than 4,000 patients across 3 different countries in the UK, in Germany, and in the United States. And wherever we looked, we saw the same thing, that higher density and high radiomic complexity of the perivascular fat consistently predicted at-risk cardiovascular events down the line in all cohorts, and independent and incremental to whatever information we could get from traditional risk factors. But we did not stop there. We kept looking to understand better the plasticity of that. So we would scan patients presenting with acute coronary syndromes, a non-ST elevation, and unstable angina that would go to the cath lab, but not emergently. So they would go through a hybrid coronary CTA lab first, and we would look at their perivascular fat and link it to what we would see on the cath. And we would see that there were dynamic changes in the perivascular fat that we could see in culprit lesions, but we would not see them in non-culprit lesions from the same patients or non-culprit or stable lesions from stable patients. In fact, the same thing we would see when we would follow patients with psoriasis treated with anti-inflammatory interventions. At 1 year, we would see like a reversal in the inflammatory signal we would pick up in the perivascular fat. And then later, COVID happened, and we actually started observing the same trends among patients treated with, among patients who had COVID and had profound elevations in their inflammatory markers. Now, this brings me to 2019. I'm like towards the end of my PhD, and my wife and I decide we need a new challenge. So we move over to the United States, and we were fortunate enough to couples match here, where we've stayed ever since. I joined the internal medicine residency program as part of the PSTP track, had the fortune of joining this amazing group of fellows. And in 2020, I had the fortune of meeting Rohan and being introduced to the amazing team in the cardiovascular data science lab, with whom I really share the same vision about what a digital biomarker should look like in 2024. And I'm going to give you some examples. We think digital biomarkers should be 1, affordable. 2, they should be widely available. 3, they should be operator independent. It shouldn't matter whether you're measuring one thing here or in a different center, in a different country. Ideally, if you're looking at the same patient, you should be getting the same number. And 4, we should be capturing things that are meaningful in terms of biology and structure. That brings me to the second layer, which is how we can use AI to standardize our measurements and hopefully provide more precise phenotyping in our methods. So let's take the simple example, relatively simple example of aortic stenosis. So the way we classify aortic stenosis, and we've always done so, is by looking at, at the 2D echoes, but also getting Doppler parameters that we know to a certain extent can be flow dependent or operator dependent, angle dependent, and therefore there's some variation there. What if we had an automated metric that could reliably compute the whole spectrum of aortic stenosis phenotypes from 0 to 1, flagging the whole evolution and natural history of the disease, simply using a 2D echo from a parasternal long axis acquisition? This could enable scalability. This could be applied to point-of-care ultrasound. This could really become something accessible. So we've done that exactly by analyzing more than 10,000 echocardiograms done in this network, that had the whole spectrum of aortic stenosis phenotypes from no AS to mild AS, moderate AS, and severe AS. And we computed DASI, short for Digital Aortic Stenosis Severity Index, that can reliably compute this evolution in the phenotypes. And we've shown across different cohorts that this has an accuracy of up to 98% in discriminating severe AS from moderate AS or mild AS or no AS, simply by looking at the parasternal long axis video. Now, the beauty of that is that it requires no changes in the acquisition protocol. So it can be applied both retrospectively and prospectively. And obviously, this could have implications for point of care, for example, screening of aortic stenosis, or also as an additional readout when we report all our Doppler measurements, because it might be less sensitive, and we know it's less variable depending on the angle positioning or who's doing the study. But it may also have prognostic implications. In fact, when we look at the same patients, so different patients than the ones where the model was developed, but like same cohorts, we can see that patients who were classified as no AS or patients who had sclerotic valves but no significant stenosis, DASI, our marker, will actually flag who is at a higher risk of progressing faster. So in fact, if you look at patients with sclerosis, we can reliably find a group that has a peak aortic valve velocity progression rate of almost more than 0.3 meters per second per year, whereas there are certain patients that are much less likely to progress. And this is something that we consistently seen across different cohorts, across different modalities. We've actually seen that in cardiac MRI scans as well. And that actually predicts outcomes. So these are the patients that 5, 6, 8 years down the line are going to come back and they're going to need an aortic valve replacement, even though at baseline, their echo was read as mild AS or like sclerosis without stenosis. Another example is AICG, and there's been a lot of work in this space, obviously a lot coming from our lab, looking at this hidden patterns that we can obtain from a 12-lead electrocardiogram that can predict and identify the presence of left ventricular systolic dysfunction. What if we applied that to standardize how we track patients, for example, in the cardio-oncology clinics that are referred for treatment with anthracyclines? So this is an example of a patient in his or her 80s starting treatment with an anthracycline-based regimen for non-Hodgkin lymphoma. Baseline EF is more than 55%. 3 months down the line, she gets a 12-lead EKG. That is normal. There's some like noise there, some artifact, but the AICG model can actually doesn't see anything concerning. 6 months later, the value is a bit higher. To me, visually, it looks similar. But then a year later, there's obviously ECG changes there that any trained cardiologist would pick up. But the AICG model is almost certain that now something is wrong and that the EF is down. And yes, indeed, the EF turns out to be less than 20% at that time. Now, I know these changes are very visible to the human eye, but they're not always like that. For example, if we take patients who had reportedly non-concerning ECGs at baseline and reportedly normal LV function at baseline who started anthracyclines, we can see that the baseline probability that the AICG model provided could actually predict who was going to develop cardiotoxicity down the line, suggesting that there might be such a thing such as a two-heat hypothesis. Some people have some predisposition, some underlying cardiomyopathy that actually gets uncovered by anthracyclines. Obviously, that's a very simplistic way to look at it, but that might be to a certain extent the case. But that also has implications for surveillance. So we can track those patients and we can actually see their AICG score go up long before they get diagnosed with cardiotoxicity by echocardiography, because they get ECGs much more frequently than they do echoes. The third item that I would like to highlight, and the third layer, is where AI and digital biomarkers can really help us where we need help. And this is where I think AI is really pushing the boundaries of what we can do with digital biomarkers. And I'm going to give you the example of point-of-care ultrasound. And we all know that this is a study that is being done routinely across emergency rooms, across most health systems. In fact, in this hospital system, we do more than 30 or 40 point-of-care ultrasounds every day. And we've looked at those. We've looked at more than 50,000 point-of-care ultrasounds that were done in the emergency rooms of this hospital network over the last 6-7 years, almost actually a decade. And we've adapted our AI algorithms to try to learn from the hardest cases and find phenotypes that we would not normally look at on a point-of-care ultrasound, not just in a fusion or a low EF, but look for things such as hypertrophic cardiomyopathy. Patients look for amyloid cardiomyopathy, look for aortic stenosis. And for many of those conditions, we actually see that we get a positive screen 1, 2, maybe 3 years before the diagnosis is established by means of like an MRI or like PYP testing. Now, the truth of the matter is that I've been talking about different modalities, but our world, it doesn't work like that. Our world is multimodal. In fact, I only spoke about imaging modalities mostly so far, but patients are more complex. They have their own history, they have ECGs, they have their wearable data. So how do we integrate everything? And this is the last point I would like to highlight, which is work we've been doing over the last 2 or 3 years, trying to put everything together and really better define the complexity and the heterogeneity of our patients. And we've been doing that in the context of clinical trials because these are very well phenotyped cohorts. And what I'm giving you here is like 3 examples from 3 major studies, SPRING, PROMISE, and CANVAS, all looking at different combinations of diagnostic or therapeutic interventions. Every dot is a patient. And for simplicity, let's say that each neighborhood corresponds to patients that are phenotypically more similar. And what you can see here in different colors is the random assignment of the different arms, the treatment arms. And obviously, they're randomly distributed in the space because this is a randomized clinical trial. But when we implement statistical machine learning informed by the heterogeneity in the population, we can see that the benefit that these patients derive from the different interventions actually varies significantly. For example, most patients do benefit from intensive blood pressure reduction. When it comes to functional first or anatomical first testing for suspected coronary disease, things are a bit more equivocal. For canagliflozin in patients with diabetes, most patients will derive benefit from cardiovascular benefit from canagliflozin, but the extent of the benefit will vary, and that won't be the case for everyone. Obviously, all that comes with significant challenges. First of all, how do we ensure that what we build is equitable and is accessible? We are mindful of the fact that a lot of the data that we use come from patients that happen to interact with the healthcare system, right? Maybe someone could attend their outpatient echocardiogram, and that's why they contributed data to our system and our models. And we need to always be mindful of that and trying to actually swim against the tide and try to derive models and define models that we can bring to the point of care. So point of care ultrasound, wearable models that are more easily deployable. The second one is we really want to make sure that the risk that we're capturing is modifiable. And therefore, we have treatments and interventions that we can recommend for what we're measuring. That's increasingly becoming the case as we get more novel therapeutics across a range of cardiomyopathies and other conditions that were traditionally underdiagnosed. And now we keep looking for them because we know we can treat them. And then the third thing is that we want to make sure that we improve patient care and we improve patient outcomes and we improve the user experience. And that should not be taken for granted. And there's only one way to actually address all those different things, which is to always randomize and treat like an AI digital biomarker the same way we would treat like a drug. Show that using the biomarker compared to not using the biomarker or integrating the AI system into our routine actually improves outcomes and improves our experience. With that, I would like to thank all of you for your attention. I would like to thank again Rohan for all his mentorship over the last 4 years. I would like to thank the amazing team at the Cardiovascular Data Science Lab, who are amazing, have no words for them. And obviously it takes a village. There's a lot of people that have contributed and worked with us along the way, and hopefully many more for the years to come. And of course, I'd like to thank my family and my wife, Sophia, who's been an immense sense of support. And without her, I could not have done anything. Thank you.
For Inga.
First of all, let me start by congratulating both of you. This is really just impressive. It just really highlights the strengths of our organization and that the future is quite bright with brilliant people like yourselves focusing this. Inga talked about translational imaging, and you're talking about translational AI. And so this construct of moving these concepts into human care is really just it's so outstanding, and there's so much future, and we just really want to congratulate you. I have very brief questions for each of you. One, Inga, could you tell us a little bit about, I don't know if you noticed, but I was involved in this space for a little bit. There was always a concern around the arrhythmic potential of these alginates and these hydrogels. What in your hands were you able to identify whether that was true, and if you could predict it based on the information? And maybe just as a quick follow-up to Evan. Evan, what you mentioned randomizations. I guess I'm getting through to you, which is good. And I think that's hard, but I'd really be interested in knowing what you see as the subsequent challenges to do that now that you've mastered how to get the outcomes data so effectively. So, but 1 and 2.
Yeah, so I'll start with at least the animals that underwent the hydrogel for in our study actually did not show any signs of arrhythmia. I believe EKGs were done 2 times at morning or at the beginning of the day and the end of the workday, at least I believe 4 days after the hydrogel delivery, and then daily throughout the study period. So we did not see any evidence of significant arrhythmia. Really, where we saw arrhythmia was usually in the myocardial infarction stage. So
I mean, I'm a big proponent of randomized evidence, and certainly I think that we should be holding digital tools to the same standard that we hold like everything else in medicine. There are challenges, though, as you mentioned. I think one, maybe, I don't know if it's the most important one, but one that we've been thinking a lot about is the fact that we don't know how deploying those tools is going to change behavior, and whether that's going to create a feedback loop where introducing the biomarker is going to change behavior and how we report things or how we treat patients. So therefore, the input of what the biomarker relies on is still going to start changing because the biomarker is introduced. So that can create like a complex loop where like the input changes because the biomarker now exists, whereas it was developed in an environment where it does not exist. And that's where things such as continual learning come in, and creating platforms where the biomarkers can actually adjust to data drifts or data shifts. But in some ways, that's no different than like a clinical trial of a drug. Maybe clinical trials of drugs should also have expiration dates. We used to use beta blockers, or I mean, we still do, but recommend them universally for patients with like ischemic heart disease, or 12 months after their MI, even if they have a normal EF. But now maybe that's going to change, and that's because like things change that we don't capture in the original clinical trial. So I don't know how we're going to factor that in.
You're a proponent of learning healthcare systems, and that'll help us, I think, as we navigate those strategies. Yeah.
And
I'll go with the 5 and then.
Hi, yeah, beautiful work. And I'm going to follow up on the arrhythmia part. So you're injecting hydrogels that are non-conductive, and they're appearing as patches, islands, and that does seem like a perfect storm for reentry.
yeah.
And in that context, arrhythmias are, as you know, multiple hit phenomena where it takes multiple hits for the unmasking of sudden death. And so did you try to look for arrhythmias, to do induction studies, to challenge, to look at vulnerability in order to expose the potential risk that might be dormant and just needs a provocation to be unmasked?
That's a very good question, and short answer is no. We did not do any significant. We basically the only arrhythmia assessment that we did was just through. We had it obviously the animal under continuous hemodynamic monitoring throughout the study, and just did a sporadic and just like a very short EKGs post. So we did not do any kind of like electrical mapping or anything like that, like you would see in the EP. Almost like an EP study, but that would be very interesting. I think also what the way we delivered these gels is really just like with almost like a rudimentary 3x3 grid. So we just kind of like, I think this is where the infarct is, and I think like this is probably roughly where it is. So I think the future is to deliver these gels a little bit more with a little bit more guidance. And particularly, I know the White Trick Lab is exploring with doing a TEE and getting really this amazing, beautiful TEEs that would allow us to do like live strains. So that would maybe direct us where exactly we could deliver the hydrogel more intelligently, if you will. So I think that's probably a little bit more intelligent way of delivering these hydrogels instead of kind of this rudimentary, if you will, 3x3 strain.
Thank you.
Yeah.
Okay, check that it's on.
Well, time is late, so I'll try to figure out how to pretend that this is only one question. But first of all, congratulations to both of you. Outstanding work and very, very, very strong presentations. Worked with you both clinically, and you're both terrific cardiologists. You're also terrific developing scientists as well. So for Inga, I'm curious about the cause and effect relationship between the improvement in strain based on hydrogel injection and the angiogenesis. So what causes what? Is it the improved sort of geometry that allows angiogenesis to flourish, or is it the improved angiogenesis that leads to the improvement in strain? And I think I can't help myself, but in terms of the mechanism of angiogenesis, one thing I would tell you to, or suggest that you take a look at is, even though you don't see the signal of increased inflammation in the myocardium with the hydrogel, there are resident myeloid cells within the myocardium at baseline normally. And hyaluronic acid stimulates activating receptors on macrophages. So, and MACs produce a lot of angiogenic factors. So I don't know about iohexol and other sort of newer kind of generations of what that would look like, but there's a possibility that the hydrogel is stimulating resident myeloid inflammatory cells, not in an inflammatory context, but in a pro-angiogenic context. So I don't know how many questions were in there, but anyway.
So one thing, why we're seeing increased alpha V beta 3 integrin activation and reduction in or some favorable, at least probably less compensatory strain in the remote segments. I cannot really tell you exactly why that is. And the correlation probably we see in a normal ischemic injury, we see there like if the typical relationship is that with ischemic injury, the myricyclotide or the alpha V beta 3 integrin activation goes up, and then that goes with a decrease in the function as well. What we saw in ours is that there was a significantly stronger relationship between the decline in function and increase in myricyclotide imaging or signaling. And then just looking at the strain just by itself without the correlation, we saw that there was indeed within the hydrogel there was significant drop as well. And we know that with injecting into the myocardium, it bulges out and stiffens up the myocardium, and then decreases the left ventricular dimensions. So one of the interesting things that, or we unfortunately cannot get or answer, or questions that we had, but we are not really able to answer from our data set, is that what if there is anything, if early stimulation of angiogenesis that was a little bit better would provide a better perfusion profile compared to the treatments, possibly. One possible thought that we had is that by decreasing the LV dimension and increasing the wall thickness, then we're basically decreasing the real estate of the left ventricle. So as you can imagine, with if I pull on a vessel, the diameter is gonna shrink, so it's gonna limit the flow. Maybe has that something to do with it? Other thought that we had is that integrins can also be induced or activated with mechanical stimulation, basically. So now with the integrin or with the hydrogel inside the myocardial wall, is that continue to provide basically mechanical construction, mechanical transduction into increasing the alpha V beta 3 integrin activation. We're not entirely sure, but those are all interesting questions that I'm cannot really provide an answer for.
That's good. Thank you.
So not a question, but just a comment. And so Inga said, thank you for believing in her. And I think we should thank them for believing in us and believing in the training program and also for taking advantage of the opportunities and for their outstanding citizenship, both of them through the course of their training, really outstanding examples in all facets of what you've been able to accomplish, and the growth and the expertise that you've shown and developed here has been truly outstanding. So congratulations to you both.
We can take a picture with the three of you.
You should also mention multiple children.
Oh.
Is this going to get as many likes as the Rolls Royce picture?
I don't know.
That's great.
The bow tie.
The bow tie, yeah.
Really wonderful example of physician science and training program, P32.
Yeah.
You were kind of in, but then you got F32. So we can see, really just wonderful stuff. Congratulations to both of you, your families.
It's just really, I mean, that was spectacular. I mean, that should be a commercial endorsement for physician science training. So great job.
Well, good job as well.
That was phenomenal, guys. That was amazing.
Thank you for coming.
That was great. Yeah, of course.
You always speaking.
Exactly.
You always have that title. I can no longer.
Something to remember.
Court.
Amazing word, congratulations.
Thank you. Thank you.
That was just so
Thank you.
impressive.
Last year we didn't get to do it in person.
I know, yes, I
Yeah, it was
know.
like snowy day.
I know. It was, I was disappointed, it was like, as you know,
It was also snowy day, so not many people were doing anything else, and I think a lot of people love it.
oh, you know, I like that, like, positive
That's how I
training.
think about it. 120 people.